Well, hello, everybody. Welcome to HeartBrief. This is Joel Kahn, medical doctor, triple board certified preventive cardiologist in Michigan and in Florida. And I hope you're well. And we've got three very exciting brand new research articles to share that may make a difference in your practice with your patients and maybe even your own health. So let me go right to the share button and see how this all works. And the first one we're going to look at is, I think, the headlines that we're seeing in many lay papers and news magazines because it's a very topical conversation, particularly with Heart Month ongoing right now. Journal of the American Heart Association, first author Alexa Friedman, Sex Differences in the Age of Onset of Premature Cardiovascular Disease and Subtypes, the Coronary Artery Risk Development in Young Adults Study, also known as the CARDIA study. This has been going on for quite a long while, since the early 1980s, and they recruited a group of young people, average age 25 years old, without known heart disease, and did many visits with them in terms of questionnaires and labs and testing. Some of them had calcium scoring. There's dozens and dozens and dozens of publications from the CARDIA database group, led, prominently by the senior author Donald Lloyd Jones, MD. And specifically in the study, a little over 5,000 people at age 25 on average were enrolled in this study and followed for 34 years. So they were followed till they were 60 years old. Quite a remarkable ongoing study. And the question here was men versus women, incidence of coronary disease, and average age of onset of detectable coronary disease. And what they found was really no surprise. Men reached a 5% incidence of cardiovascular disease 7 years earlier than women. That would be at age 50 versus age 57. But the curves really started to diverge at age 35. I'll show you that. That at age 35, this has big implications in our practice. So if you look right here at figure one, cardiovascular disease, coronary heart disease, stroke, there was not a big difference between men and women. It was coronary heart disease predominantly. And if you look at these graphs, that certainly by age 40, but statistically, even at age 35, men started to climb and climb and climb. And it wasn't for another 7 to 10 years that women started to climb in terms of incidence of coronary heart disease. So this raises the question, certainly not unique data. We got data from soldiers in Korea that died of trauma, and they had autopsies, and we saw a very high frequency of atherosclerosis even in their 20s. We have similar data from Vietnam and Desert Storm in soldiers who died of trauma, and the incidence of coronary disease. It's quite remarkably high. So here they're going by clinical grounds, not by autopsy grounds. And it's not quite so high, of course, because clinical disease is a little more difficult to identify. But do we start screening people at age 30 to 35 for advanced labs, cholesterol panels, lipoprotein A, inflammation markers, homocysteine levels, glycemic markers like hemoglobin A1C? Do we start considering men for coronary artery calcium scoring at age 40? I think that's a good idea, but it isn't national policy yet, although it was proposed to the MAHA movement in the last 2 weeks that this does get incorporated as a routine test. We'll see where that goes. But age 35, we're already seeing significant detectable coronary disease. So there's another famous study from Spain called the PESA study, where the average age at screening was age 44 and about 4,500 bank workers without any known heart disease. 50% had evidence of atherosclerosis at age 44 to 45. Now they looked at carotid and heart and femoral atherosclerosis. So it's definitely there. If we look for it, maybe we should start looking for it routinely. Okay, let's go to another very interesting article here in HeartBrief, the journal Hypertension, estimating the potential impact of the 2024 UK salt reduction targets on cardiovascular health outcomes and healthcare costs, a modeling study. First author Lauren Bandy. So this has been published in a preprint. It's not fully released yet, as you can see by some of the markings on the paper. But what they reviewed is that for a number of years, the British government has been recommending salt reduction, and salt should be less than 5 grams a day, is what is being recommended. But the reality is, the average amount of salt intake daily in the UK has been between 8 and 9 grams a day. They were making some success, and there was starting to be a reduction in the daily intake of salt by education and talking to people about reading labels and about added salt, although most salt in the diet is not added salt at the dinner table. It's in prepackaged foods and fast foods and vending machine foods. It's in the food already, including bread and chicken. So they estimated what would happen if we reinitiated this big effort in the UK and were able to reduce salt intake to the goal, 5 grams a day of salt or less. And what they calculated was quite impressive in terms of actual savings, that they estimated that in the next 20 years, 100,000 cases of ischemic heart disease could be prevented, 25,000 ischemic strokes could be prevented, massive savings would occur in terms of medical healthcare costs just by public education, makers of food education, and policies that tried to steer the public closer to this 5 gram a day salt goal. So we didn't hear that in emphasized in the new food pyramid by the USDA about 3 weeks ago. There was very little discussion about salt, and some people criticized that we missed the boat on a very important public health topic. But good to see that in England, at least, they're bringing it back up. Simple measures, just maybe get a salt substitute with potassium chloride in people with healthy kidneys. That's also been shown for pennies a day to replace sodium chloride and to lower the chance of hypertension and all the consequences of hypertension. All right, ready for the third article here at HeartBrief. And the third article is another fascinating one, published in Canadian Medical Association Journal, January 26, 2026. First author, C.C. Yang. This was called the EAT-Lancet Planetary Health Diet and Risk of Incident Chronic Kidney Disease. So basically, they went to the UK Biobank database where people have very intense questionnaires, dietary intake. They had 180,000 participants, and none of them had chronic kidney disease at baseline. Over the course of 12 years, they had 4 different definitions of chronic kidney disease. But of the 180,000 participants, almost 5,000 developed chronic kidney disease in these 12 years. They looked at what's called the EAT-Lancet Dietary Index, a diet that was proposed about 7 or 8 years ago as being both good for the planet. That's why it's called the planetary health diet, one that's lower in greenhouse gases and carbon dioxide emission and others, as well as being good for the human entity. And it's a very plant-forward, whole food diet, no processed food, very little animal food in it. And what they found was that in this large database, the higher the adherence to the eating pattern called the EAT-Lancet Planetary Health Diet, the lower the risk of developing chronic kidney disease. And it was across the board in all the different ways they defined and measured chronic kidney disease, but the risk went down and down and down by eating foods that we know are good for the heart, good for the brain, good for glycemic control, and now good for the kidneys. So if you look here at, I believe it's figure 3, and you look at the green graph in the upper left, that is the adjusted hazard ratio for incident chronic kidney disease based on adherence to the EAT-Lancet plant-forward diet. And you can see in green, the higher the adherence to the EAT-Lancet index, the lower the risk of chronic kidney disease. In fact, it looks downright protective. And by other measures and other definitions over time, this was found to hold true. So plant-based diets are becoming, more commonly recommended to chronic kidney disease patients. Worry about the potassium burden in fruits and vegetables is becoming more relaxed. It says right here in paragraph 2 on page E79, a key commonality amongst the dietary patterns is their emphasis on a higher consumption on vegetables, fruits, and nuts, and reduced intake of red meat, components consistently associated with lower chronic kidney disease risk in previous studies. So there you have it. When you talk to your patients with hypertension, with diabetes, polycystic kidney disease, maybe a slight rise, BUN creatinine, or my favorite kidney blood test, cystatin C. And as long as I'm saying that, my favorite kidney urine test, microalbumin creatinine ratios. Bring up this EAT-Lancet planetary diet pattern. Bring up whole food plant-based patterns. I have my patients watch documentaries like Forks Over Knives, You Are What You Eat, another very important, What the Health. There's a very good one. What the Health is a great documentary online. And they can make some moves and learn a simple step like making lentil chili instead of beef chili. Simple steps like that have a big impact on many aspects of the health, including their kidney health. So thank you for listening to this episode of HeartBrief. 3 very important articles that could fundamentally change long-term outcome. We're talking again about salt reduction, we're talking about plant-forward diets, and we're talking about early detection of coronary heart disease in young people, with men developing this much younger than women. Thank you.